Thank you, Rajesh, and good afternoon, good morning, friends. Indeed, refractive surgery is one of the, I think, leading surgery in the ocular field because of large number of our people do require refractive corrections, especially younger patients. And there has been a lot of innovations, technology change in recent years also. And SMILE is there, which has come in the last so many years with us, and you know that started way back in European countries because this is a system developed in Germany. FDA approval we got in 2016, and there are few advantages which would like to highlight is you do have a less adverse effects, especially there are no flap related complications. And second important thing is the incidence of dry eye is very minimal, and we think that it will give you a better biomechanical stability of cornea after refractive procedures. There's a learning phase in the of SMILE surgery. Unlike LASIK, it does have a little learning phase, and these are various complications which can happen intraoperatively: suction loss, black spots, opaque bubble, cap lenticular adhesions, retained lenticule, and cap side cut. And these are very important issues which happens in phase of learning, and they are surgically challenging steps in these cases. This is what we published from center, our initial 100 eyes of 50 patients, and the initial complications were there where we had a side cut extension to the area, and tear which is going a little away. You can see an opaque bubble layer which is diffuse and difficult dissection happening in these cases, and the cap tear which happens because of difficult dissection and difficult dissection because of OVL, or you can have a suction loss. So these are a variety of complications, or you can say a difficult situation which comes in the intraop phase in these patients. So one of the most significant surgical step is a proper dissection of lenticule cap and the lenticule base in these cases, so that you can take out the lenticule without causing too much of a damage to the surface, both anteriorly and posteriorly. This is just getting cut because one is you can dissect first anteriorly, which normally we do it, then subsequently dissect the posterior plane of the lenticule. So once you dissect the anterior plane, you have a posterior plane dissection better. But suppose you go directly posteriorly first, then your anterior cap lenticule attached to the cap, and things become very, very difficult. And that situation should be avoided. A subsequent complication, like I said, extension of a tear, like the side cut tear or cap tear, or difficult lenticule dissection, retained lenticule, all these are complications because of poor dissection in these patients. Incidence is quite low. It may be a little higher in the beginning, but subsequently becomes very, very less in these cases. So these are various things we know that you can use a Sinskey hook assisted peeling, or you can identify the dissection by taking the patient to anti-segment OCT and doing subsequent dissection also. And the Sinskey hook dissection is very, very simple in these cases. You can see here, once you use a Sinskey hook, you can just peel off the cap, the lenticule from the cap, and subsequently you can dissect out like this, and things become easier in these cases. And we described how to really pick up the anterior posterior in these cases. Normally for right hand surgeon, first we dissect anteriorly. You can see this is a circle which is there, which is missing when you dissect the cap. And if you have a circle, that means you have gone posteriorly directly. Then come towards the left hand side, dissect the posterior area. You can still see the circle here, and push the edge little away. You have a meniscus sign coming up. Once you have this, the things become very simple here. You can see in this picture also, you can see this little bit of a disturbance. That means the posterior part has been detached, and the subsequent dissection become easier. You can clearly see this is anterior, and this is posterior because I can see that my instrument is behind the lenticule. If that flap you can see, then your dissection becomes very, very simple. Just see here, this is one of my case where I had a cap lenticular adhesions, and I would remove the little bit of OVL from the incision area, open the incision in a manner. This is a 2 millimeter incision. First I go towards the right hand side, go up to the periphery here, then subsequently come to the right hand side and go posteriorly here. So this is what I am trying to dissect it out. So if you have these two areas clearly defined, then subsequent dissection becomes simpler. So I am doing this anterior dissection here, and the dissection is done quite smoothly. You can use a spoon-like dissector which has a wider surface. The area of dissection becomes simpler, and especially towards the right hand side, things become little easier also. Once I complete my dissection, then I have to look for the deeper part. I'm missing the deeper part here. So what has happened, maybe I had gone directly posteriorly to begin with. So this is a blunt spatula. I'm not damaging the stroma. If you use a sharper one, you can damage the stroma also at this stage also. So what to do next now to use the same thing? If you see, go back to the first step only. You can clearly see the meniscus sign developing in the initial dissection only. I missed that. If I would have known that there's the meniscus sign, my dissection would have been simpler. Now you can see the meniscus sign coming here. My sharper instrument, I'll just detach this, and this detachment, I'll come to the central area. The entire lenticle can be taken up to center. Now use a dissector and take it over this now, and you have now simple anterior dissection coming up. So this is what I'm doing here, the anterior dissection being done. Once you have dissection, you can take out this lenticles now very clearly. In fact, the surgery, like a routine surgery here, entire lenticule has come up. I'll just make a gola of this, and you can take it out without using a forceps also. The idea here is to identify the plane to begin with. This may be difficult in some cases where you have edema or you have a OBL, but you can still do it. Let me take you to again a second case of mine here. Same thing is being done here. I'll remove the OBL here, make the incision clearly dissectable. Sometimes you do have a incision not very clearly open if you have a little bit of suction loss happening towards the end of surgery. I'll just see this little difficulty here, but subsequently I'll make sure that my incision is nicely opened up. At this stage, you can damage the incision because the flap is very thin. We don't realize 100 micron flap or 120 micron flap. And sometimes you can create the epithelial defects also. That is not desirable. Now go anteriorly and dissect out the anterior phase. Then subsequently the posterior dissection will be done. So that's a routine technique of mine, like right-handed surgeon. First go to left-hand side, dissect the anterior part, then go to right-hand side, dissect the posterior part in these cases. And subsequent dissection is done similarly here. So once I dissect out the anterior part clearly, then I'm again in same case, this case I'm struggling to go posteriorly. Therefore, I again miss the anterior plane here. So here, if I go back a little bit, in this particular case, I can easily see the meniscus sign here. So I'll just push the entire lenticule towards the 6 o'clock, and you have a cleavage coming up. So once you have a cleavage seen, and that is by the meniscus sign you see, go anterior to that, you can push the entire lenticule backwards. Hold this lenticule with the forceps, and you can just do a rexus and comes out. Make sure you examine your lenticule after you remove it for its completeness. And that is very important. Sometimes when you tear it off, you may have a peripheral lenticule piece remaining, and that should be avoided in these cases. It's a little bit of suction loss, which is a second important thing which can happen in these patients. The major causes can be, incidence is very less. I have seen only 4 suction loss happening in my 1,000 eyes. As you get more experience, the things get more simpler. So these are various causes by which you can have suction loss, inexperience or early phase of your surgeries, or tight speculum, improper drape, or you have an anatomical factor like deep set socket where the suction is, because the suction is very mild in smile patients, very uncooperative patients. Therefore, actually when you run the laser, the patient has to be absolutely comfortable. And this laser application is just not more than 30 seconds. And those 30 seconds are very, very critical for patient to realize they don't have to move or blink their eyes. And you have to explain these patients properly. So once you have a suction loss, how do we do it? If you have a suction loss happening before 10% cut of a lenticule, you can repeat that immediately. If it is more than 10% of a posterior cut, then you have to abort the surgery and plan something else. Similarly, if it happens at a side cut, you can redock it. If it's a cap cut area, you can redo it, or cap side cut, you can do it. It's only when you have done posterior cut more than 10%, then you have a little difficulty in these cases. Less than 10%, you can redo it immediately in these cases. This is a few of my videos on initial learning phase. So this is one of my patients. You can see not very comfortable, moving the eyes, a lot of fluid in the, near the suction ring here. If you have too much of fluid, that's a cause for suction loss also. Immediately suction loss happened. Nothing went wrong in this patient because I could realize patient is not comfortable. I made that area dry and reapplied my same cone, application lens. I could do it very nicely in this patient. The surgery was completed effectively. So there, it was my mistake not to counsel properly the patient. The counseling of patient for a stage is very, very important. So this is a second patient where suction loss happened at more than 10% of inferior cut. You can see more than 10% of posterior cut. So I could not repeat the smile in this patient. So I took this patient after 6 weeks of initial procedure for a routine flap procedure. So this is one indication what Dr. Chitra was saying. You may have to do a flap after a waiting period of 6 weeks in this patient. And make sure this would have been side cut. The new hinge was in the temporal side, in the nasal side in this case. Just to take another case of suction loss here. This happened towards the end of my procedure here. So I had done already cap cut and side cut complete. I had to do a anterior cut, and I could redock the same patient at the same time with a proper explanation. First, dry the interface contact lens, and you can redo it subsequently. Make sure your centration is perfect, and you can realign in these cases. So suction loss does happen, but it depends at what stage the suction loss happens. The machine as such will tell you what is to be done. You don't have to really worry, and it will allow or not allow, and you can do the surgery here. So again, the same thing is being done. I have got an anterior cut now, right of the periphery, and side cut will happen, and the surgery can be completed. So it's not very difficult to manage. Most of the suction loss also, they can be done effectively. And looking into all the aspects of smile surgery, you do have a little learning curve. You require little surgical skill in your patients. Have a little patience of learning of smile. Do a wet lab, see videos, assist some surgeons, and know the tricks to avoid complication in your patients. Lenticular dissection, as I showed, anterior posterior dissection is very, very important to not to let complication occur in your patients. And intraocular suction loss, very rare, but once it happens, you can re-manage very effectively in your cases. Thank you for kind listening. These are our publications, and this is my book on smile. Those who are interested can have access to the book available through JP Brothers and Amazon, and you can have a nice video collection through that also. Thank you.